Um, uh,
So far. It's good. Okay.
Got it for
This,
you. Turning it over to you.
sure. Looks like I think I'm suspicious it could be a low volume meeting because I got about 7 or 8 people telling me they're either stuck in airports or they're like Amal was trapped in that Denver snowstorm yesterday, and or other things that they have to be off to. And for example, there's a bi-monthly meeting that Rob Dunn's at and so on. But we'll still have a pretty good crowd, and I think most people will start joining us here in just a second. All right, I'm trying to see if there's anybody else I need to.
Also, it's spring break.
Yeah. Oh, that's right. What's that?
Exactly. What's that?
Right. Remember, I'm in the heart of spring break. Remember, there was a movie in the 1950s called Where the Boys Are that was filmed in in Fort Lauderdale. So that's it. And it is busy here. There are just still kids galore, traffic is come to a screeching halt around here. So that's it. All right. So there's a couple things I do want to get. Let's see. Let me look at the chat here. I'm listening, but I can't talk for a bit. Okay, that's good. So Jim, good. Thank you very much for putting that in there, Dr. Augustine. So a couple things I'm going to try to get done today. Allison Zerba helps run our trauma program here in Broward County, and not just tries to run it. She does a great job. It's been fabulous having, and you've met her at our Eagles meetings, most of you. And she had a question last week, but like we wanted to know about who's using pelvic binders, and y'all got a what do you call it? The word survey out that Mark and Stein put out, and hopefully most people have answered it, or if you can answer it right now, so we can have pretty good data from around the country, especially since we represent a large percentage of the U.S. And so I'd like them to have that information. So I thought they're having a meeting next week, so I wanted to have everything put together. So we're going to talk about that today, and we're going to see if Stein can get some of that collated for us pretty rapidly. Secondly, I want to talk a little bit about a couple things. Like a few weeks ago, we had Dick Simpson on and presented some of the things he was thinking about. He wanted to see what the group was thinking. And so I'm going to do the same with Chris Colwell. Chris sent me about 7 or 8 really great topics. If it's Chris, it's going to be really good. And so I still wanted to see what people were very interested in, if I had to cut it down to 1 or 2 topics under the circumstances, that kind of thing. Stein, what have you found out so far? Hey, Stein, did you find out anything yet?
Sorry, Paul.
Yeah.
I'm trying to get a hold of Mark. We are in the middle of the biggest snowstorm that Colorado.
Right. I know that.
Year.
Yeah.
And so I'm not sure where everybody is right at the moment. The city canceled everybody coming into work, and so I'm trying to get a hold of them. Right.
Oh, so that's fine. I just wanted to see if you had heard anything yet. Okay, but we'll get the information. Either ways, we'll get it to her. I just thought we could also start the conversation as well and see if there's pros or cons that people found about certain products, etc. And that'll be it. So we'll get to that later. I also want Chris to be able to come on and talk a little bit about some of the subjects that he wants to do. I still have to go back and forth here and move some of the folks over from the from the other side here. So, but here we go. So, okay. So let's start off with a couple of other things. One is, let's see, any chance that you're there, Johanna? Are you there? Sync-Q? Captain Sync-Q, are you here today? So one of the people that I want to have you meet is going to be a person that handles all the hotel issues that we will run across when the time comes, and want to make sure that if you had any questions, you know who it was, etc., and so on. Especially since there'll be people who are going to pay for their own hotel rooms, but we could maybe get the discount price. We can go through her to make sure you get a really good price for yourselves even. And then, of course, she'll make the hotel rooms for the people that we're paying for up front. And if there's any problems with your rooms, like I found out last year, we had problems. I remember we were trying to check in Chief Hood last year, right, David? And he and there was a screw up there. And so Johanna and her husband came over and fixed it right away. So that was really very, very helpful. That's why I want to have you meet her and get plugged in with her early on, all that. So let's go back over just as we're waiting. I was going to wait for 1 or 2 more people to get on, but I did want to quickly just ask Allison, what prompted this issue about pelvic binders here in in Broward County? Are people using them, not using them, or you wanted to raise the question to see what we should do or what's the best way or protocols? What were you looking for?
Well, there's a mix of agencies doing different types of binding in the field, and some aren't at all. So
Yeah.
as a Trauma Systems Quality Improvement Committee, we wanted to just put out a position of a recommendation from us on what they should do. Doesn't mean they have to.
Yeah.
But we wanted to see what's working for everyone so that we can pick the best form.
Yeah. Okay, got it. All right, so I think it's pretty straightforward and all that. And I'd like to go around the room and hear what it is. I have one hand raised that says it's panelist, but I can't see who it is. Maybe I don't have this thing set up.
Oh, it's me.
Who is,
it's my-
okay, yeah, David, go ahead. I don't know why you didn't show it here. That's why. Okay, but go ahead.
We really like the SAM splint because it has the inertia driven click. And so you know that you're in and on. And the other thing is, in part as quality improvement, is a lot of people put them too low, right? And so they're
Yeah.
not the femoral head. But the other ones, the one with the looks like shoestrings, our guys have broken those in trials, and they
Okay.
don't provide a consistent pressure. So that's why we like the SAM one the best. And the SAM one is very compact, and it works very well. We even train our EMTs to do it.
Oh, yeah, that makes a lot of sense too, to have them do it. So that's good. Hey, and then do you have a protocol then for it? Like whether the indications, or do you leave that up to judgment of the providers after training, or how do you do
Judge
that?
and provide, if they think that there's a pelvic fracture, they can put it on. And if there isn't one, they just take it off in the ER. Who cares?
Yeah. Right. Okay, got it.
And we put it on as part of C in marches. So stop bleeding, get an airway, open the chest, get to the truck. And it's part of C after TXA blood and Recepin, and use the pelvic binder or splinting as part of the C in control circulatory process.
Yeah. Okay, got it. All right. And then anybody else have experience with these, and what do you use, and any disagreement with what David said? And by the way, David, you do have a protocol though that we could send along to Allison as a model, so we don't have to reinforce.
I'll look and see. Yes.
Okay, got it. Okay, good. There's another hand that just went up, and I'm sorry that I can't tell who it is. There's something wrong with my thing here. I don't know why it doesn't tell me who it is. Who's got the hand up?
Oh, I got my hand up, Paul.
Oh yeah, Fiona?
We use a product in the UK called the Prometheus splint, which is very considerably cheaper than the SAM splint or the T-Pod. It's a lot simpler to put on. It doesn't have any clicking or anything like that. So it's difficult to put it on too tight or too loose, but you can reduce the pelvic fracture. And you can use it in children and adults. It's just a question of cutting it to size. So it's really simple to put on. If you want to see what it is, if you go on YouTube and go to Prometheus pelvic splint, it'll show you what it is. But we use that all the time now. We use it as part of our HOT protocol for traumatic cardiac arrests, and we use it for any patient where the mechanism of injury suggests a pelvic fracture. And it's really simple to put on.
Okay, fantastic then. Then same thing, do you have any protocols that you could send along to Allison? And Allison, can you put your email in the chat by any chance? Could you do that for us so people can send you things?
Absolutely. And I thank everyone for your input.
Yeah, and then make sure everybody gets to meet you at the meeting, and because you've always been so helpful to us, then they'll say, oh, it's her, right? So that'd be really good. Okay, good. Anybody else have any experiences with other devices, or want to support what Fiona was saying or what David was saying?
Oh, the military at the conference we were at the other day, they use it really was a junctional tourniquet, but he
Right.
said that they use it as a splint as well, where after it's placed, you can actually blow up that little cuff that goes it kind of pops out right over the groin area.
Mhm.
I don't know the name of that, but apparently that's what, this guy's from the SEAL team. Apparently that's what they use. I'll try and figure out what that one was, and I'll put it in the
Okay,
chat.
got it. Anybody have any information on what that might have been? Or no? Okay,
Yeah, that's probably the AAJT, the abdominal aortic junctional tourniquet.
right.
I'm
That's what I
just
was
going to throw out my contention. These are all great, and I agree with what's been said about the SAM splint. Lots of great things with these commercial devices, and I still will contend that as long as you put it in the right place, a sheet works too. And for some of us that that doesn't include San Francisco Fire, of course, but that we work with some agencies certainly that are not able to put commercial devices on there. And I'll just throw out that the sheet does work as long as you are sure you're putting it in the right place.
And make sure you're not full of sheet. You have to make sure you have enough, right? So, okay. Okay. So, all right. Anybody else have any commentary? Or
Well,
things
we
going-
don't have sheets on ambulances anymore. They're paper.
Yeah, that's right.
Don't you care about patients, David? I mean, that just seems like this is a patient care issue.
Yeah. So let me do this real quick. I'm going to go and see. Obviously, we have an issue in terms of having a collation, but I don't think anybody will have any problem saying, because it's public knowledge out there, what you're doing. So I'm going to share the screen and pull up what I got so far overnight on this thing, and that'll help you with Allison, so you don't have to hang on here. Oh, you're welcome to stay, by the way, but I just wanted to make sure that you. Let's see if here's Mark Worth. This is what I got. I think last night might have been the last one. Oh, wrong one. Sorry about that. I think that's the wrong thing here. So you get back over here. Maybe it came in on it. It probably come in on it. Let me check my emails here and see if I can find it. Should have had this ready to go for you. I'm sorry about that.
Well, it looks like that second tab at the top in your Chrome has an Eagle survey.
Oh,
there.
Eagle survey.
Yep.
That's it. Good job, Peter. Okay. Okay, so very good. Let me get rid of this thing over here because I can't read anything. So just to give you a general idea that I'll take out these affiliations here real quick. Oh no, this is Peter, that's here's the public binder one. Here we go. Okay, here we go. So we've got does your agency have guidance? Yes. And you can see there's a no, there's a yes. There's a couple of no's, but for the most part, there were yeses there. Okay. And but still people with no's in there. So does your agency have guidance or protocols for the use of binders? If yes, do your agencies have improvised a pelvic binder? So a la the sheets, right? So we do have a yes, and we've got a couple of more yeses here. Most of the part it's no or not applicable, right? But there are a lot of yeses in that, just so you're aware. Okay. And I may ask people what you do here, and I'll come back to a second about this issue about the improvised binder. And then if you generally stock a commercial binder, yes or no, and then if so, yes, one. So a lot of SAMs here, as it looks like. The T-Pod binder here, right, that Ben uses, we'll ask about that in a second. And then there's the Prometheus that we were hearing about from Fiona, okay? So I think that's pretty good. We gave you a little bit of the early feedback that we're getting from people. So it's now I want to get some more commentary on this. So let's just go through. Let's see, where was the improvised one? So Dustin, are you on by any chance? Dustin Calhoun or Stein, or let's see, Eddie, Joe Holly, Crawford. Any of you guys have any commentaries that you want to make about this? Let me get out of this. I think that's enough of the sharing that I have to do. So let's see who is on here. Who is it that was saying that they were using improvised system? I guess I don't see any of those names here. Mark Cohen, you're going to do some stuff in LA pretty soon, aren't you? If I remember.
In regards to the public binders?
Yes.
Nothing set just yet. So looking at them, but nothing more formal.
Okay, got it. Anybody else here that's using, I guess on the list that said improvise, there's not enough people here to see what that was. But it looks like the majority of people were using the SAMs. And then who was using the T-Pod? Stein, are you using that? I can't remember. Or Stein, you're one of the people that was using an improvised approach, right? What are you doing?
We have a combo. We're actually using the SAM, and then we also have a different product that we're trying out, but the SAM is what we use mostly.
Oh, okay. Got it. All right. I thought it said that, and maybe I read it wrong, that you were doing kind of an improvised approach. So I'm just kind of curious to hear what is said. And then anybody else have any protocols they can send to Allison? And Allison, did you put your email in you did, you put it in the chat, correct? Okay, got it. All right. Well, in any event, can you put the link to the pelvic survey in the chat, and I'll put it in officially. And then can you do that for us or send it to him again? Stein, can you make sure that Clayton gets his his whatever surveying. All right, I hope I haven't beaten this to death too much, but at least also I hope this gives you a little bit of a start or a little bit of a feel about what's going on there. Hopefully we'll get you some protocols sent to you, okay?
Very helpful. Thank you guys so much.
And you're welcome to stay on, by the way, whatever. So let's first go over to Sandy Schneider to get a report from ACEP. And also, Sandy, I don't know if you're in a position or not. I'm sorry about what you've been going through, but I don't know if you're in a position not to talk a little bit about what what you had told me about last night.
Yeah. So again, sorry, I've been having some eye surgery, and of course, routine minor surgery turned into be just a freaking disaster.
Yeah.
But we're getting there. I will sight eventually. Just not right now. And it's only one eye, so I can't.
Was
really-
there just some oversight there, or I'm sorry, but sorry
Yeah.
about that.
I'm really blind to the results. Yeah, whatever. So what I sent to Paul, and I hope maybe he'll send out if it's appropriate. OSHA has posted new rules regarding EMS and fire response safety rules. And these rules have several areas where they could be a problem for EMS groups. I sent this to Paul last night, pretty late, or actually sometime, I don't, before we had the hailstorm. But basically, there are some items that are going to cause potentially increased cost, mostly around infection control. Infection control will apply to all agencies except volunteers, and then there are some subsegments of volunteers that will have that as well. There's some stuff about hazard exposure. ACEP is writing a comment letter about this. I'm assuming NAMSP is writing it as well. One is about violence. One is about just the impact of the sort of moral injury on this. There's another area where I'm just trying to find there where they talk about seat belts. And make the driver of the ambulance responsible to make sure everybody has a seatbelt on for the entire duration of the transport. That's a little bit strange. We thought that was going to be tough for ambulance drivers because the cab is often disconnected. And so you might not know whether or not there's a seatbelt on or not. And then we were going to use this time to maybe attack the 8-minute standard for response, because that makes sense for fire companies that they have an 8-minute, because a fire in a house is probably different than somebody who calls and says, I just cut my hand with a bagel knife, or I sprained my ankle. So we have that. They don't have that, quite the triage piece in there. Anyhow, take a look at that. Paul, I don't know if you want me to send it out or you guys want to send it out.
Well, yeah, maybe you could send it. What I did is I just sent it to Jim Augustine.
Okay.
And maybe Jim,
Perfect.
can you, what's the word I'm looking for? Abstract that part of the email and then send it out to our folks. Is that okay? Is that a good way to do it? What do you suggest, Jim?
Happy to do that. Yep.
Yeah,
I'll take care of it.
this is open for public comment. We're commenting as ACEP, again, NAMSP to do it, but other individuals can do it as well. While I have the floor, a couple of things. Committee.
Hey, listen, you're not on the floor. You got the walls and the ceiling. You can have the whole thing.
I got this in here, baby. Committee applications are open, so if you want to serve on an ACEP committee, please fill that out. It's very easy. It's acep.org/committees. Wow, how exciting. Also, at the same time, abstracts are open for research form. That closes April 30th, and that's easy as well. It's acep.org/SA, standing for Scientific Assembly. Once you get there, it's actually a little harder to find, but it's in the top drop-down boxes. It's in the first drop-down box. I don't know who creates our websites. I sometimes think they're on some kind of drugs. But anyhow, you might want to look at that. I know Paul's been talking with ACEP about doing sort of a mini Eagles possibly at ACEP. We also have a request out if you're interested in putting together a non-CME course. So there's something you think ACEP should do. Those are open as well, found in the exact same place. First tab under ACEP .org/SA. And if you go there, you can just you'll see course proposal. You can put in a course proposal for any course you want. You know, it could be anything that you think ACEP might want to do, and hopefully you'll get it.
Let me interrupt there, just so you know that this has been, we've worked it out pretty formally now with Bobby Hurd and Ansley. And so we do have something, they're going to supply CME as well for us. It's going to be a day-long thing on Monday, the 29th. We went out and polled the group to see who was going to be at ACEP and anyways going to be there, such as people like Chris or Jim Augustine that we've just heard from, will be out there. And so we're already got topics put together, and now we're just trying to figure out timing during the day. For example, even including yourself, are you committed at a certain time and you can't make it? So I want to put the agenda together according to what people's other outside commitments are there. Alma Matu will be there, and several others. So we're looking forward to plugging in. I think it's gonna be a good show. And if anybody is gonna be there and didn't tell me before, now's the time to tell me, like the next day or two. So, all right.
It's
Good.
gonna be.
Sorry. Thanks for letting me interrupt you. Okay.
Yeah, it's in Las Vegas. I mean, what could be better than Las Vegas, right?
And then speaking of bagel knives, you got to have Bagel Mania up there near the convention center. But you guys are gonna be, but this is not gonna be at the convention center, correct? This is
Right.
gonna be held at the Mandalay Bay, if I remember correctly, right?
Right. It's at the Mandalay. I'm already starting to look for my dinner reservations, because there's a couple new places there that literally are filling up almost as soon as they open. So
Yeah.
start thinking Las Vegas. Fiona and I don't see Mick on. We're actually going to have a special thing for international posters. So you can put your poster through the regular route, or if you want to put a poster in and you're coming or know somebody that's coming, we will have a special thing. Just have them get in touch with me.
Does Florida count as international?
I'm sorry. There are a couple places in the United States. If Florida goes, we might have to take Texas with us. Okay. And I'm not sure about some of the other places. Alabama's not looking all that great these days either.
Okay.
I think you've seen the things, a seed is not a plant, and an egg is not a chicken, that kind of stuff.
You got it.
There's a new section starting on behavioral emergencies. So if you've got anybody that's into that, particularly in a pre-hospital area, just again, take a look. We're signing up people up for that. The leadership and
And I
advocacy.
presume because like almost probably 20 or 30% of our calls might be related to some kind of behavioral issue, one way or the other, whether it's drugs or just mental health issues, crises that are going on. It's a large part of it. I presume when you say behavioral emergency, it's going to be the whole spectrum of things that we have to deal with, correct?
And I really want to bring some people on in the section who think about pre-hospital care, who think about mobile crisis units, who think about, what are the issues around sedation of these very, of the people with hyperactive delirium. I think that would be part of it. But if people from pre-hospital aren't on the section, then it's going to end up being, the typical suicide, et cetera.
Yeah. Okay.
I think it looks like Gam put something in the and LAC is next month. It's early this year, April 14th through the 17th. And then the next day, excuse me, sorry, wrong thing, reset. 14th through the 17th, DC, Grand Hyatt, usual thing, go see your legislators. It'll be great. And then we look for some stuff on measles next week. We set up a real quick little group. We'll have some webinars and such, and we'll be sending that out. That's really all I have to mention.
Yeah.
I think I like about everything.
I'm just glad to see you, and I'm glad at least hopefully you're on a more recovery path now. So thank you so much for being here and so on. Yeah.
Not a problem. Is just don't come at me from my left side because it's sort of fingers.
Okay. I'll keep that in mind. All right. And then Gam, do you want to talk a little bit about the educational agenda while I got you here?
Yeah. I just have 2 minutes. So I dropped a link in the chat to what's called a request for information, which is posted in the Federal Register. This closes March 31st, and it's requesting comment on EMS Education Agenda 2050. It's really a revision of the EMS education agenda from 2000 and is looking at how EMS education systems will evolve over the next many years. So we already have about 63 public comments in, but please click on the link. Encourage you all to submit comments before the deadline. It would be greatly appreciated. Thank you.
Okay, anything else from the Department of Transportation we should know about from your end?
Just one quick thing. One thing we are looking at with motor vehicle crashes is in the rate of entrapment. One of my staff actually just looked at 2021 data from the Fatality Analysis Reporting System, FARS, and found, to be honest, to our surprise, that 1/4 of all occupant fatalities in vehicles are trapped in the vehicle and require extrication. So really just looking for folks to look at this issue from a state and local perspective, and be interested in any thoughts or hearing what you're actually seeing in the field.
Okay. Any comments on that? Anybody who has looked at that formally yet? Maybe it's something we all could look at formally now to help you out on that. All right.
Yeah.
Well, good. Well, Gam, thank you so much. And Sandy's, thank you so much for reports. Let's then pivot over to the fire department side. Jim, anything? Yes,
Paul,
go ahead.
if I can say one thing regarding the entrapment issues.
Yes.
Nicole Boston, name very familiar to our group here. I don't know if she's on today, but has been working with the trauma compendium we put together through NAEMSP, the Standards and Practice Committee. Has been working on a position statement on that and resource document that includes a lot of the stuff that what you're talking about. Is going through Standards of Practice now, but it's really very well developed. And so Nicole might be a really good resource for you for that.
Yeah. And hey, Clayton, can you put that in or get that to Gam somehow? To her contact?
Absolutely, I can.
Great.
Okay.
Thank you. Much appreciated.
Okay, good.
Gam,
All right.
this is Jim
Go ahead.
Augustine. I've hardly got a voice. I apologize. Don't forget 2021 is marked by the kind of the change in vehicle patterns. We noticed in Georgia an up spike in injury crashes and traps
Right.
as COVID came on, because there were so few vehicles on the road that the speeds were high and enforcement was way down. And so we had a pickup in fatalities, injuries, and traps.
Yeah.
I think anecdotally, we have a lot fewer traps than we used to. And if we do have traps, they are fatalities. I think the modern construction of cars is contributing to us being able to have people, from sometimes really bad crashes walk away, much less not being trapped. And we get to older vehicles that get in accidents, and then we're back to bending metal and cutting posts and stuff. So I think there's a success story built in there.
So it'd be kind of interesting. People could search on Jaws of Life use or other extrication equipment. Just that alone would be an interesting thing versus, they were trapped in the car, but we pulled the door out easily, that kind of thing. So it'd be interesting to break it down to that level, I would suspect, right? I don't know if that's something you could do or not, but just a thought. Jim, anything else out of IAFC or IAF,
No, One Voice is working in the fire service, bringing together the lead organizations to speak on behalf of the fire service. And again, Lori Moore Merrill has been very successful in bringing the fire leadership groups together. We should, Sandy, there's a good lesson in there.
Okay, got it. All right. So anybody else have any time constraints? I want to make sure I catch it before I go on to Chris's comments here. Anybody else have any commentaries that they'd like to bring up? If not, I'll move on. Lakshmi, good to see you. By the way, I got your message. I'm sorry we're going to miss you. I was going to say, what kind of lame excuse is that? Is going to visit your parents in India, right? So just because they're older, right? Aren't they going to be older in 5 months? No, just kidding.
No,
but
unfortunately, everybody's vacations. That's the only time it lines up, and
yeah,
they're getting older. They're having some major health issues, and unfortunately, we have to make the trip.
I know. Oh, no, and I'm just joshing with you, of
No,
course.
and I was actually sad. I was like, oh, I wish, and I tried to move it around and I just couldn't.
Well, yeah, so we will miss you though. But anything to report while I got you, heads up here, I just want to let you know I got that, and I was sad, but I loved seeing your face. So, how's all the ABCs doing? Okay.
Everybody's good. Atlanta is Atlanta. I mean, I love that Jim was saying, those speed limits are just a suggestion. Everybody drives fast here. Vehicular collisions are just a daily occurrence. We have finally, we're starting whole blood out in the field on Sunday, St. Patrick's Day.
Wow. Okay.
Just been gearing up for that. And
good timing.
exactly. And if everything goes well, we'll start on Sunday. And it's interesting because our winter, usually the summer surges, like our last summer, it never settled down after. It's been at that same level all the way through the winter. So we'll see what the summer brings.
Yeah.
Doesn't it get a little warm in India that time of year?
Just a tad hot. But apparently, our summer trauma surges. We'll see if it's going to get worse. We're really going to struggle.
Yeah. Well, we'll be holding a place for you anyways, and we'll toast you. So, but no, but with my fondest thoughts for your family, and I understand exactly what's happening. So it's good. It's just great to see you. Hey, and then I assume that are the kids going, and is your husband going as well?
Everybody's going to go. Everybody's
good. All right. So let's see, there was something else I was going to ask you. Oh, I was just thinking about St. Patrick's Day now that you reminded me. Is I went downstairs, the place where I live here, and they were giving out free donuts apparently for jokes. And I didn't notice that. I just happened to go down and usually did my usual thing where I told a joke and I said, top of the morning to you, because they're wearing some like green hat or something. And then I said, and the rest of the day to myself, and so they said, you get a free donut. So I just want to let you know if you guys.
Okay. Yeah, we're giving out whole blood.
Yeah, right. Exactly right. That's a good timing, quite frankly, because there are going to be a lot of drunk people out there one way or the other. So, all right. Let's see. Let's go on. Let's go over then to Chris, if you don't mind, unless anybody else has any other things they want to stick in pretty soon, because Chris is going to take up the next 10 or 15 minutes, I think. Okay. If not, I will move on to him. So, Chris, you had, I told everybody when we started that you sent me about 7 or 8 different topics that you were going to maybe review. And
I think there were actually 12, but yeah.
Yeah, right. Well, yes, but any event, but we talked last night about 2 or 3 that might be really interesting. I want to see which the group would like. Now, to set this up a little bit, because I think anything you hear from Chris is going to be great, and we may still be able to fit it in here or there. But we also got to make sure everybody else gets to talk. But we wanted to see, for the purposes of ourselves at Eagle Creek or for the purposes of the general audience, what would be the thing that would be most useful to them? So I just wanted to get some feedback, just like we did previously with Nick Simpson, which was really helpful, by the way, to have the feedback from the group. So, and hey, Nick, just let's have Nick comment, that was useful to you, wasn't it, if I remember correctly? So, by the way, right?
It sure was, yeah.
Yeah, and then so you came with some thoughts about how you wanted to do it, et cetera. So, and I did too. I wrote some really good notes down. So I thought this might be a good thing if you guys want to present some of the things that you're saying. Well, which one should I present? This would be kind of a fun forum to give us a heads up on it, and then we'll hear the drill downs later. So, Chris, what are some of the questions that you wanted to ask? You have 3 different topics possibly that you wanted to at least present to us as a group, correct?
Yeah, no, and I appreciate you're also making the exception for me to give me 30 minutes on each one of these talks as opposed to the fun. So
that was 30 seconds, Chris.
You appreciate that.
Chris misunderstood me. It was 30 seconds, not 30 minutes.
So yeah, no, these are topics that I have talked about and have generated a fair amount of interest, questions, commentary, but it's hard to see on that kind of the national scale the need for them, or at least which of these would kind of come higher on the list. So the 3 that were kind of thrown around most are geriatric trauma, the precipitous delivery, and assessing capacity in the field. And there have been specific requests for each one of these, and putting those talks together, in response to those specific requests, I wanted to get a better sense, from this group, whether there would be any value in doing something like this at Eagle. So the geriatric trauma one is really.
Let's prioritize a little bit. What we're going to say here is that let's say, think about this for the general audience. Which one of these would be the best for them, or all of them, whatever. And then what would be great for us to hear more about and drill down on in our own group, or both. Okay, but let's start with the main Eagles meeting. Go ahead, Chris.
Okay, so the geriatric trauma one, it's my general contention that there is nothing we do more than geriatric trauma, and as we all, even that includes many of the medical aspects of it. And if it's already not the most common or one of the most common things that you're doing in your service, it will be. And we've made that argument for a long time in terms of the epidemiology of this country and our population. And that geriatric trauma, while often getting lumped into general trauma protocols and particularly triage protocols, is obviously extraordinarily different. And I think we all appreciate that, but we haven't delved down into some of the details, and in many cases aren't treating them differently. Whereas I agree, if my 85-year-old, not mine, but if an 85-year-old grandmother gets stabbed in the heart and into the right ventricle, the management of that is probably the same as most right ventricular stab wounds. But I will say I've seen a lot in my career. I have not yet seen an 85-year-old with a right ventricular stab wound. They don't tend to get stabbed. They fall, and they fall for very different reasons. And I think honing down on how we can best change our management in geriatric trauma and change our approach to geriatric trauma in the field is what I'd really like to focus on with this one. Recognizing that there are different mechanisms, different causes, different vital signs that we need to be looking for, and therefore should really be approached in a different fashion than what we're doing now, where they're being really too much so, although I think we're better, but we're still lumping them too much into the general trauma category. So the couple of questions that I'd really like to answer for this talk would include, what are the key issues we need to be aware of when managing geriatric trauma patients in the pre-hospital setting? And then how are geriatric trauma patients different, and how does that impact pre-hospital management? So how are those different mechanisms, different injuries? And we've kind of agreed, I think most in this group have certainly agreed that they're probably better off at trauma centers than not. But I think that's actually overly simplistic. And the only reason that has been the case is because the data has looked at trauma centers versus non-trauma centers. What we haven't looked at is those specializing or with having truly geriatric focus. And I feel like rather than just sending them all to trauma centers, that we really need to identify the group that actually would do better at geriatric focused areas as opposed to just simple trauma centers. And I think we're starting to see some data that would support that as well. So this would focus on those things.
Let me interrupt you for a second then. So what I'm hearing from you is maybe that first question asked is that why is geriatric trauma different? And we had a debate just yesterday at our EMS chiefs meeting here in Broward County about, what do you do with the 55-year-old that's on a blood thinner, et cetera, and they hit their head even if they are conscious or whatever. Do you take them in or not? As that thing came up, Peter Antiev, if you're on, would you add anything to that? What was, and everybody was thinking they would go to trauma centers there, but then Chris was saying maybe we got to figure that out a little bit better. What do you remember that, Peter? Or are you there?
And I know Jim's got his hand raised too.
I'm going to go to Jim in a second. Yeah. Well, obviously he's not on at this point in time. But anyways, the point is, I think that'd be a really good one to say that. And should we have a separate geriatric protocol or triage or whatever, just as David Miramanis is saying in the chat, where they have a different one? And those were addressed to some extent, I think, in the recent ACS. But I think it's a great topic that maybe we should split it out as a separate topic because it's a growing issue and all that. Okay, Jim Augustine, go ahead.
Yeah, I just was going to comment. This conference is in Florida, which is God's waiting room, and the percentage of geriatric trauma here is just overwhelming, and they're all forms, Chris, except not as much penetrating. But we have a lot of elderly drivers who get in bad crashes, and we under triage them. We over triage the simple injuries, and two pieces to that. Number one, that the trauma staff just get complacent when it comes to geriatric falls. And then number two, many of the geriatric patients who have fallen, broken their wrist, don't want to go to the trauma center because they know that that's a madhouse, and they want to go to the community hospital, perhaps more so than our younger patients. And so in Lee County, in addressing this, our trauma center says, take the elders to the non-trauma places because they don't want to come here. Our staff doesn't treat them well, and many times they're big complainers. So Paul, I know you're in that, and Tevi's in the same. You might want to think about that as part of your Florida audience here. Thank you.
Correct. And then, so yeah, and I think that's part of the issue, is that there are a lot of those those aspects to it, and people just don't want to go in, and because they know they get, and then it's not comfortable for older people being there waiting over hours, waiting for hours and all that. David, you want to comment on that, because you have your issue about your triage in San
Yeah, so
Antonio.
I'm trying to, we talked about this last week about the national 2021 ACS guidelines for trauma triage. Does include a little geriatric flavor.
Yes.
And I fought this fight in my region. Let me tell you, it was a fight, because this idea of taking geriatric patients not to the closest catchment hospital, but to a level 3 or a level 1 trauma center instead, let me tell you, that was a market share driven fight. But we have the red-blue criteria that I posted in the web. And what it means is 2 geriatrics, 2 blue. But what we built into it is one of the blues is age over 65. So you really only need 1 more. And I think it's important, like Chris said, that we need to treat them very differently, very aggressively. We PI every MedCom transfer, that is an upgrade, a trauma from a low level to a higher level of care. And almost all of them are trip and pulse with head bleeds, right? And so I think it's about time that we start treating old people a little bit more aggressively in the trauma system. Also, never transport old people to a freestanding ER, because 9 times out of 10, that simple wrist fracture ain't a simple wrist fracture. It's hip and a head, it's ribs and a wrist, it's multi-system trauma. So,
and how we're defining old people, and as I get, and I get more and more into this category, it becomes even more important.
65.
Oh, not 64 in 10 months, 65. Okay. Hey, yeah. So yes, remember I was on a talk recently where I was talking about ECMO in the field, whether we should do it or not, and I was talking about ECMO protocols that you can't get it if you're under 70, and in some counties where you could get it if you're up to 75. So I told them I had conflict of interest because I could only get it in certain places, that kind of thing. But I mean, it is interesting to define what is elderly. Is it chronological, or is it something else too? That's an interesting point as we go through this. But yesterday, hey Peter, are you on? Because remember, they came to conclusion in our area that they're going to talk about anybody who's over 55 and on any blood thinners, they were going to a trauma center. Is that right? Do you remember that? Are you on, Peter? That's why I brought him up. I guess he's still tied up on that whatever he was doing. Okay, but so I think it's a good question, and it's a good debate. What format do you think we'd have? Just a straightforward lecture, or have 2 or 3 people comment on it, like Jim just did, just like we just did with David and Jim and Chris? That would be a good. Anybody suggest format for this one, or is it worth a panel to talk to the audience about? Anybody have any thoughts?
I would vote panel, because I might actually push back a little bit. So I live in a nice suburban community here in LA. And if you take me to the nearest trauma center, it's a public trauma center where the orthopedic surgeons there usually do the 30-year-old femur fracture on the motorcycle accident. And it's a public hospital with a lot of knife and gun club. And the 70-year-olds with the mechanical fall, the hip fracture and the rib fracture, the local community hospital has cardiothoracic surgery, neurosurgery, orthopedics that do a lot of hips, and they're just not a trauma center. They're not interested in being a part of the trauma system, but the elderly patients can get great care there. Yeah. So I don't know that overwhelming the public trauma center is the right move either. Yeah. So I think a panel with a little bit of point counterpoint and some unintended consequences of of rerouting the patients might be valuable.
Yeah, and it's kind of interesting because I actually recently had experiences where we, for that very reason, we had a person that probably had an isolated injury to the head only, bumped it or whatever, and was having some altered status. So the question is, do you take them all the way down to the trauma center, or do you go to a comprehensive stroke center, which has theoretically neurosurgeons there? But what does that mean? How fast can they get in? How fast can they take care of it if it was a isolated head injury, et cetera? And then in all of your experiences, are you seeing other trauma? If you're on blood thinners, for example, are you seeing other kinds of things besides head? Are there bleeds in other areas that are significant that could be life-threatening? Anything else that you're seeing commonly? I should put it that way. There's always the odd cases. Anybody?
I would
All right.
say predominantly head.
Yeah, you're right. Exactly right. Okay. Well, so that's it. You go to a place that has a neurosurgeon, but then you find out that they're out playing golf right then. They can't get in right away when they have an evolving, hematoma up there in the brain, whether it's epi or subdural. So interesting question.
And just to be clear, I'd say I was actually saying a very similar thing to what Clayton had said, is that the answer that we've come up with so far is to bring everything to trauma centers is not the answer. It might have been better than just routinely just going to non-trauma centers, but that we have to step this up and actually start to look at where they are best served within our communities. And it's not always going to be at the trauma centers.
Well, and then that also brings up the other issue is that the hospital side, because then the hospital side says you screwed up, you should have taken this to a trauma center, and that comes up as well, right? So that means we also have to make sure part of our discussion is to talk about how we communicate, interact with our in-hospital folks as well. So on this one, okay. I think it sounds like a good topic, and I like the idea about going with the panel. But more importantly, I want to see what Nick Simpson has to say. Okay, go ahead, Nick.
Thanks. This is quick. I'm just curious. One of the things that we've done recently to try to not overwhelm our level 1, we have a lot of lower level trauma centers in our area, but just a couple level 1s. And one of the things we do is if they're, awake alert, normal vital signs, normal neuro exam, and a fall on thinners, we allow those to start at the lowers, but the ones who are altered, et cetera, those need to go to the level 1. And I wonder if kind of having a little bit nuanced triage that way is something other people are doing.
Yeah. And then, so anybody have any response to him? So one of the things that, go ahead.
I was going to say, we send ours to a level 3. And the reason why we want to send them to a recognized hospital that has an intact CQI process in a verified trauma center is because you want to make sure they're catching their errors. You want to make sure they're in a system of care that's going to manage their head. Oh, and by the way, they've got a paranephric hematoma. By the way, they've got rib fractures. Oh, by the way, they've got this. So I'm not advocating taking them to level 1. I'm saying take them to the appropriate level trauma center that has a system of care with performance improvement and, more importantly, external oversight, either by the state or by the ACS, to make sure they're doing what they say they're doing.
Yeah.
And in some areas that might look like a level 3. In other areas that might not. That is going to be somewhat area dependent. And that's what I think we need to push for is criteria, not necessarily it's a level 1 or a level 3, but it is an institution that meets the following criteria, different from what necessarily a trauma center in and of itself. There's some overlap, but not necessarily the same.
All right. So Chris, I think we have enough fodder here to go on to the next step. And Fiona, I'll come to you in a second. But let's do a panel. One question I did have for Nick, though, Simpson, is that when you said a person on thinners, okay, again, this comes back to the what's old, right? So what if you're on blood thinners and you're 40, for whatever reason, does that apply there as well? But particularly we're sensitive to the older people because they, whatever, they won't have their heart rates up or because they're on beta blockers or whatever it might be. And there's so many other aspects to it there. So Chris, this is a good one. So I think we'll try to work on a panel and have you lead it. Okay. Does that sound okay?
Absolutely.
All right, Fiona, comment. And Jim, do you have another question or you had your hand up or just that was from before? Jim Augustine.
Before, sorry, I'm taking it down.
Okay, it's no problem. Fiona, go ahead.
Yeah, my question was just around the availability of intercostal nerve blocks, because a lot of the elderly patients that we take in have got rib fractures, and the average time to get an intercostal nerve block in a major trauma center, we don't talk about level 1, we talk about major trauma centers and trauma units. In a major trauma center, you're likely to get a intercostal nerve block within 6 to 8 hours. If you're on a trauma unit, you might get it in a couple of days, and that's just not acceptable.
Yeah.
So it's just another aspect of what we call silver trauma.
Yeah.
I'm
So we
getting
should,
very now, and I'm really keen on this being managed well, guys.
yeah. So I think that if there's a way to break it down to, if you can isolate head injury versus the others, but maybe you can't tell, especially if they have altered mental status, that's the other problem. So, okay. Well, I'm going to have you take a crack on it, and do take a look at what David is doing, take a look at what everybody else is doing. If you all can communicate them, then we'll see if we can create a nice little panel on this. I think it's really appropriate, and timing is right, since the baby boomers are moving up into the upper 70s, and that's it's going to be prime time for what we're talking about here. So good
Okay.
job.
Yeah,
I
no,
think you're on.
that sounds good. Do I have to involve David? Because as we all know, I don't particularly, David and I don't particularly get along very well.
Right.
So, if I have to involve David, it's gonna look a little different. We're gonna have to sit on opposite sides of the stage, that kind of stuff.
And can you wear, like, someone's in different colors or something like that? Jeans, like kind of thing. Right. Okay. Sounds good. I love it. All right. Now let's go on to let's see. Oh, what was your next topic? Here we go. I see we're going on longer than I thought. This is good though.
So
Good discussion.
Whereas, the topic we just talked about, geriatric trauma, is something we all see every day, every shift, in different moments, but we certainly are going to see that on every shift kind of a thing. This is something we're not going to see every shift. And in fact, many of us won't see it very often. But we have a fairly consistent 3 to 4 precipitous deliveries a month. We have a large population of folks that don't get prenatal care and wait until the very last minute. So we get about 3 to 4 precipitous deliveries a month. So lots of paramedics aren't going to see this very often. But in terms of this inspiration came a number of years ago when essentially I was involved in a twin breech vaginal delivery in the ambulance, and recognized that there are basically 3 primary complications of a precipitous delivery that we can make a difference on and need to be aware of. It's the breech, it's the shoulder dystocia, and it's the prolapsed cord. And those 3 each have 1 or 2 things that we can do.
Oh, you say shoulder dystocia? I just could like.
Yeah, breech delivery, shoulder dystocia, and prolapsed cord. I'm simplifying a little bit, but those are the 3 primary complications that we can and should recognize in the field and can do a relatively simple maneuver to address. And since it's not something that we're going to see very often, I think it's important to remember and remind ourselves of a couple of those things to do. And in 5 to 8 minutes, I think we can go over the primary issues you'll face, how to recognize it, and what simple maneuvers can be done. Granted, it's not going to happen often, but it can be a dramatic impact, and we have seen it in our agency. And I have a couple of places that have asked for that specifically. So I'm throwing that out there. I don't know if that's of interest to the general population, but that's one option, one thought I was thinking of as well.
My first reaction is that's actually great, and it's gonna be perfect for one of our 5-minute, whatever, get to the point. Here's 3 things that you could do something about, and you set up the reason why we don't do it often, and so it's just a good reminder. It's just like when Ben did his thing a couple of weeks ago about how we have to be reminders about the woman who's having a seizure. And she doesn't look pregnant, so you're not thinking pregnancy, but you got to find out, is she postpartum or not? These little reminders about those cases that come up are going to be really good ones to do. So I think, so I personally, that's my reaction. Anybody else have a reaction or anything you would add to that, by the way, to those 3 things he's talking about? Well, Fiona, anything else you would add to that, you think, to that list, or does that sound about right?
I think that sounds about right. The ones that we've had have been postpartum hemorrhage, massive postpartum hemorrhage. And what a crew will do about that, the shoulder dystocia, prolapse cord, and fitting. Yeah, I think that those 4 probably are the ones to go for.
Okay. So you can maybe throw that in at the end then because that may go off to a different direction because you're talking about some simple procedures we could do right now and then do a little tag on, or we could have someone else talk about that, such as David or someone else who's had issues with treating postpartum hemorrhages. What's the latest thing we're doing in those arenas? But what if you don't have blood? What if you don't have TXA is another good question, under those circumstances as well. Okay. Those are, so is that helpful to you then, Chris? Is that good? Everybody else agree with that? Is that it's worthwhile putting it out for the general audience? Okay. And any discussion, anything else anybody would add to that? Okay. Well, I think that sounds good then, Chris. Then at least we got some good feedback too, especially talking about the postpartum hemorrhage, the thing to consider. And it may not fit into the context we are, but we may be able to make a little panel there or a mini symposium with somebody else discussing that particular issue. And then maybe even you, Fiona, you could talk about, how you guys manage that. That would be a good one. All right, then let's go. What was the third topic you wanted to go over today, Chris?
And the last one is, the assessing capacity in the field. And we've talked about this on a couple of different levels in the past, but we just did our education session for the residents as they're getting ready, our fourth year residents getting ready to answer the biophone. And we recognize that of the cases that we go over, and this is a 6-hour session that we go into a lot of details, but far and away the most difficult ones are assessing capacity and the interactions with the base hospital. The orders, the advice, the consultations, those kind of things can be interesting, but are generally nowhere near as challenging as when we are faced with a situation where we're needing to assess capacity in the field and decision making for patients that do we transport them? Do we transport them against their will? Under what circumstances? And how do we assess that capacity in the field? So it would be what are the elements of capacity assessment? It still drives me crazy that people talk about alert and oriented ×4. And how that somehow relates into capacity, where I would say that it's almost unrelated, not entirely unrelated, but almost unrelated. And certainly orientation does not define capacity, and at least not by itself. And what are the most important considerations in assessing capacity in the field? And how do we do that? How do we do that in that communication with the base hospital? Understanding the challenges to both. It's one thing for the base hospital to help with the decision of capacity, and then making a decision on transport of a patient that obviously has risks associated with that in somebody who's trying to refuse. So it's to address those primary issues in 5 to 8 minutes.
And then the other thing is, Chris, even just before you get to that, is discuss, people still use terms like competency. So just to break into it, start off with competency versus capacity, because you're appropriately using capacity. I think we ought to make sure.
Competency is a legal term. I mean, as we know,
yes.
Determined in San Francisco and California and Colorado as well, it's determined by a judge, not by us. We assess capacity.
That's all I'm saying. Start off with that and let them know and say, okay, now then what's our job in the capacity arena, right? And that's one thing. Clayton, what do you add to it?
I love this topic. And the big question I would add to that is, when we have a patient who's incapacitated, and is refusing to go, and in these days where law enforcement is increasingly hands-off and kind of pulling back, how are we supposed to get that person to the hospital? Are we supposed to put hands on? This is also the day and age where, medical error and things going sideways results in paramedics going to prison. So how do we tell them what to do when they have a patient who's incapacitated? Law enforcement is not interested in assisting, and the base hospital is saying that the patient needs to go to the hospital.
Yeah, no, a key issue, and the fact that we cannot care for patients that we cannot care for safely, and we're never obligated to put ourselves in danger to care for a patient as much as we might want to. No, that's another critical issue here.
Okay, good. So that's a great set. So it sounds like this is a good topic to kind of go over and all that. And then let's see. You had raised. Looks like you raised a question, Charlie, but then I can't get you to come over to on the panel end here. So we'll try it again, or put it in the chat. I guess I'll look at the chat real quick if there's anything down there. Oh, okay. Chat. I don't see any chat yet. Here we go. I love this new system. Okay. All right, well, let's do it this way since I don't know what they're saying here. Okay, let's move on then. So anybody else have anything to add to that? So it sounds like a good topic, right? And I don't know if it's old or new for everybody, but I think just to get everybody in the plane, does everybody else have the same protocols? Are there different protocols? And I guess, is it depend on what state you're in, et cetera? Does that have an effect there as well, as far as you know, Chris? Because you've been in Colorado and you've been in California as an example. Anything different from state to state as far as you're concerned? This is all the national level thing we can
Well, there certainly are some differences, and we saw that come out in the issue with Colorado and ketamine. But and that obviously involved a lot more than a capacity issue. Although I would argue capacity was part of this. There are some different, obviously they're very different. There are different state laws. However, I would argue that there's a number of aspects of this that cross over all states, all areas in the world. And so I will focus on those and not the differences that might exist in state laws. Acknowledge those where we know of them, but really cover the aspects of this that cover all capacity assessments.
So I don't know the answer to this, but Fiona is asking if our courts are influenced by the best interests decisions. Fiona, why don't you explain to us a little bit what that means in case it's a local colloquialism?
So it's when an ambulance crew make a decision in a patient that they deem to not have capacity, and they act in what they regard the patient's best interest, which will basically be moving that patient against their will.
Yes. So I generally think that this comes down to what we talked about last week. It's almost like, especially if there are witnesses involved, is how the medics were perceived more as people and carrying people that were doing the best. And I think in general, that's what we do when we're acting in someone's best interest. I think it is influential. And just the opposite is true, is what it appears that we're just trying to do a job and get you in and everybody's hostile. It will probably go south under those circumstances, in my opinion. But I don't know, anybody else want to add to that? Anybody have a feeling about that or had experiences with it, more importantly?
Yeah, Paul, this is Mark. Sorry, I can't raise my hand. I'm actually on the road. But
okay.
Years ago in Massachusetts, when I was an ED director, our hospital attorneys made it absolutely clear that when in doubt about capacity, the best legal move was to bring the patient to the emergency department, or when in the emergency department, hold them for an evaluation, because the Massachusetts courts had made clear that that weighing the temporary inconvenience to somebody of being held against their will against the potential devastating consequences of missing critical illness heavily weighed in favor of keeping the patient. And so it was basically court policy in the state that they would weigh heavily in favor of holding a patient when capacity was in question.
Yeah, and so that goes back to, like, if this is my family member, what would I do? Number one. And then number two is making sure maybe you go through things like talking to any witnesses, family members are there, calling your supervisor that you've done everything with, with good intention, and with due, and you've made a comment and everybody's agreement with you. That probably helps a little bit as well, I would suspect. So anybody else have any suggestions? But I think the answer is yes to you, Fiona. Okay, for the most part. Kate, you made a comment that you thought it would go south, maybe, or if it got to the press, or what is it that you were reacting to? Clayton, you there?
Oh, sorry about that. Sorry, trying to get my mute button. No, it just seems in this day and age, of course. No, I think that for the most part that's true. That most of these cases where we end up putting hands on people, they go okay, it never hits the press, the patient doesn't have a bad outcome, and everything works out. Unfortunately, when it does go sideways, the patient has a bad outcome, cell phone cameras are out, and if the court of public opinion weighs in that they don't agree with it, then this day and age, we see criminal charges filed.
So
So-
yeah, that's it. And I think that goes along with what I was first saying and what I actually said yesterday about some circumstances is that no matter what you're doing nowadays, and things will be taken, let's say if someone punched you and then you punch them back, the only thing you're going to see is when you punch them back. So part of it is, or if you're at a scene, we talked about this last week with Eric Yeager or 2 weeks ago, whenever it was, I can't remember. That the cameras are on, you're on television when you're out there. And actually, so not only do I try to make sure that I'm behaving well, that I want, that I'll be on television tonight, but also use it as an opportunity for good PR actually. And to, be nice to people, be cognizant, be careful of sensitivities of people. Like if, for example, you got a person with their head cut off, like I used last week, and nothing you could do, and then you go see a friend and you're sitting there kind of, hey, how are you? And you look like you're having a good time. Those could be picked up as being insensitive, etc. So part of it is realizing that you are on camera at all times, no matter what nowadays. And I think that makes a difference, because if you come across as a caring, friendly, professional person here, it'll help you out a lot in those things. But what Clayton is saying, if you're not cognizant of that, it's going to go south. Stein, go ahead.
Yeah, not that this solves all the issues that we're talking about, but obviously there's been a lot of movement in Colorado. And as of January 1st, there has been legislation that was put in place that allows EMS personnel and law enforcement to place somebody on what's called a transportation hold. And so we've had historically a lot of resistance from law enforcement to place somebody on a mental health hold that, kind of puts them on a hold for 72 hours. And so there's been huge resistance to that. But now with this transportation hold, it just allows everybody legally to participate in getting somebody against their will to an emergency department or a psychiatric facility for evaluation. And it only lasts for a few hours.
So is that only in Colorado though, or is that locally passes or other?
I don't. Yeah, I don't know if it's other places.
Okay, so it's something so that makes it something that's of interest for everybody to know about. So that probably could emulate it in your state or whatever it may need. Okay. Well, anyway, it sounds like I'll tell you at this point in time, let's go ahead and move on. But I think that that sounds like it's another good one, Chris. We'll see how it plays out if we have time for everything, but at the very least, it's a good discussion for us to have as a group as well. So, and then it looks like you said Minnesota has a transportation hold, which is up to 12 hours. So that's kind of interesting. So maybe there are models out there anyways for those who don't have that. All right, let's do this. So Chris, you got your marching orders, right? So how's that?
Got it. Thanks, everybody.
Good. Hey, let's just go around the room real quickly because time is running out here. But I want to catch up with everyone. And so I want to see if there's anything new happening in different places, etc. So first of all, let's start off with the large city over there in the East Coast. I think it's called New York. Is that feasible? How was the funeral? Tell us what the funeral was about today, Glenn.
Yeah, it's unfortunately one of my office members who was our liaison to our REMSCO, New York Regional Council. He had actually left us to go on to the hospital sector, and he was doing very well there. But his heart was always city, FDNY type stuff. But he actually collapsed over the weekend in cardiac arrest, and his wife found him, who was a PA, and started CPR, contacted 911, and we got pulses back and forth. They resuscitated him over an hour and a half in the ED, hoping to get him back, but ultimately unsuccessful. So the funeral was this morning, and
how old was he?
He was 68, on the verge of retiring in October. So I think the moral is don't retire. I mean, we hear all
or don't even make plans to retire.
Don't even make plans, And he had the countdown like everybody does in EMS. Computer, how many months and how many days and how many hours, and it's like a prison sentence. Everyone's like, hey, how much time you got left? Oh my gosh, I got 3 years, 4 months, and 2 days. But he
how's the National Guard doing for protecting you? Everything better now, or all fixed?
Yeah, there's still some back and forth between PD and state National Guard and state troopers. There's always been something between NYPD and state troopers coming in our jurisdiction.
Yeah,
but now it's even worse, and there's a little, you can feel the tension. But that's what was agreed. Well, that was put in place by the governor. And now
Yeah.
it's our mayor's kind of backtracking, saying, yes, I wasn't there because there's a conflict, but no, we're in, we've been talking. So it's all kumbaya now, but on the ground level, boots on the ground, it's really not.
And then for you guys in EMS, what's the impact there?
Well, not so. I mean, there are these horrific stabbings and being pushed onto the track events that are still going on. So hopefully that'll slow down a bit, at least at select stations, because they're not at every station.
Yeah.
So we'll see what happens. And, civil liberties are saying, well, you can't just randomly check somebody's bag. And technically you can refuse. The law is that you can say to them, no, I don't want to show you my bag.
So let me ask you this: this is actually just a kind of an interesting technical question. Let's say you get called down to someone that pushed onto the tracks, right? And I don't know how badly they got hurt, or they slipped over, or maybe they're not dead yet, because I guess that they're pronounced dead on the scene. I don't know who does that. Number one, do you guys do it? And therefore, you have to go down to the body, right? Or two is that if you have to work them, how do you know that they've stopped all the trains coming your way, right? So tell us about
that. Third rail is always a concern for us, and we try to get it confirmed, but we tell everybody in any rescue situation, even though they tell you it's off, don't touch that third rail. Don't even step on that wooden platform above it, because there's no guarantee. And train systems, because oftentimes they get shut off by people throwing garbage and things, they automatically go back on for the most part. So you have to make sure that you let the subway station person know, no, keep it shut off, because we're trying to operate under it.
Yeah. And how do you feel pretty comfortable they're doing the right thing, so your folks are safe when they go down and do that, if they have to go down to the
for the most part, we are comfortable with it, but we still avoid that third rail.
Oh yeah, for sure. Okay, so it is interesting. And do you have particular equipment to get you down there? Because there is a little bit of a distance. It ain't, it's not. It's a little bit of a jump down there, right? Do you have particular
correct.
ladders?
And sometimes it's between stations, so they have to go into the tunnel, depending on what's going on. And ideally, we try to send the rescue units, but all of our units have the basic training. But if it's confirmed PIN where we might be able to save the patient, then we try to send the rescue paramedics to that scene as a confined space job.
And then what I was getting at is, what is the access? Do you have special ladders or special, so you can avoid the third rail, and or anything else that you do?
There's certain equipment where we put wooden platforms on the third rail while we're operating, so that in case we do get close to it, you're not hitting the rail itself, you're hitting wood, and there are no real special rappelling equipment, because getting down into the train tracks is not so difficult. Getting under takes a little bit of training and such. It's a little confusing.
All right.
So no real specialty equipment. It's just more, the bunker gear that they use, the rescue bunker gear to get in, and certain things that they're supposed to know how to manage if something goes on. You start hearing that train going back on, that, we really got to be careful here.
Yeah. Hey, so what have you been thinking about in terms of what you'd like to present at the Eagles Maine meeting this year yourself?
That's a great question, because we have not done much of anything new. I was thinking maybe our robotics unit.
You just do a lot of stuff.
But nothing of real interest. But I thought maybe the robotics, we first deployed our robo dog to the garage collapse a year ago. Unfortunately, it fell over and it was on national news, but the unit is pretty impressive. And they were so upset that the news showed that dog falling over. They're like, no, they didn't show it riding itself. They just showed it falling over. Our drone unit, we used to be tethered, but now we're free flying drones. So those and we were able to fly that into the garage collapse as well, because it was pretty unstable, just to take a quick look. So that's what I'm thinking of. Maybe I don't actually know what else. I'm still trying to figure.
That's okay. And it might be interesting for people to say, here's some tech stuff that you might be using it, and that, and so on. And that may not be a bad idea when you talk about both the drones, they talk about the robotics. That might be really interesting as well. I don't have a problem with that. You just do so much stuff that you have some tunnel vision, just like the issue I just mentioned, like when and how do you go down to the subway tracks, right? I mean, that's not what we encounter every day, and it's interesting. I didn't know the answer to that, and I wanted to know. So you maybe take things for granted too, as well. So,
and in our training academy, we have a couple of full subways. with tracks, and we built it to look like a station. The only problem is with land, space difficulties. Most of our people are like, the platform is really short. Like, okay, pretend it's longer. We can't accommodate an 8-car platform with the space we have. So maybe it's like a 2-car. And that's one of the issues they talk about. And our rescue medics are trained to rappel into, spaces, because we do have elevator shaft, injuries, falls and things. And our rescue medics are certified and qualified to go down there and start patient care there. Back in the day, it was the firefighter saying, we'll bring you the patient. We're like, yeah, well, we might as well go to the morgue, because, they look good now, but they're going to die. So they know very well now that we need to get our medics down there and, start treating as soon as we can. As long as it's safe for us, we'll get in there, do our quick assessment, get an IV in, maybe start fluids, and then jump back out. They'll continue their extrication, and then we'll go back down when we need to. But our fire side is very well versed now, because every time I get on scene, like, damn it, I know, Doc, I know, you got to get your rescue medic down there. I got you. And it's a lot more receptive, as opposed to in the past. They're like, no, you're not going down there. We'll bring them to you. And that's when then go to the morgue. It's pointless.
Yeah, got it. Okay.
And for us, our e-bike fires are still bad, but I reported that last year. Last year we had 1,800 deaths total. We just had our first one from a e-bike fire a week and a half ago, first death. And then just 2 days ago, we had a huge fire, 10 injured from an e-bike fire. Luckily, no deaths. But again, that's not so new anymore either. I know everybody else, unfortunately.
Yeah, but still going from 1,800 to 1, what was your intervention?
18 deaths.
Oh, okay. I thought you said 1,800.
Yeah, no, 18 deaths. Yeah.
But
I mean, a couple hundred injuries, but 18 deaths.
What was the intervention?
Well, right now they come out as a fire victim, so smoke inhalation and also, fire, the burn.
No, I'm saying, what was the intervention you did to decrease the number? Did you start having citations of people?
Well, I mean, it's still early, but, our commissioner's gone to the city to try to get city council to pass certain things. Also, she's testified at the state and at the federal level to say, listen, we really need to look at this. But again, it's March now and 1 death, which is great, but they're going to be more.
Okay.
Yep.
Well, let's go
now
ahead.
They're actually, we're trying to figure out what kind of, toxins are being produced from these bike fires. We're trying to get a little more detail as to what's the danger to our firefighters and medical personnel going in addition to the patient, of course, but do we need extra respiratory protection? And I don't think that's necessary, but we're trying to look at that now. It's going to take us a little while to get that answer, but we're looking at it a little more deeply.
Thank you then. All right, let's tell you what, let's go to city number 2 then, population wise. Let's go out to Mark Cohen in LA.
So we managed to get through the Oscars last week. No events at the actual event. Had one syncopal that the PA took care of at the governor's ball afterward. But got a fair amount of feedback that it was a little bit of a waste of resources. So maybe scaling back those types of VIP things. But gearing up for the marathon that's coming up this year. Or this week rather. So Sunday we're going to be dealing with that and the usual typical headaches. But it looks like the weather is going to be pretty decent for marathon in terms of low 60s and decent humidity. So hopefully it will be fairly uneventful.
Okay, so let's move over since we're in the neighborhood. Clayton, anything to report out of the county?
No, we're in partnership with Mark for the LA Marathon, and then we also have a 4-day rave going on at SoFi Stadium. So could get interesting, but we'll see.
Oh, one of my favorites. You should talk to Chris if you haven't handled those before. If you've had a few, Chris Zuber would be a really good person to talk to. Off the top of my head, because he's handled those all the time, particularly things like the Electric Daisy Carnival and all that. So let's see. And then Lakshmi, we talked to you briefly already. And Mark, let's just go up the street then. Let's go up 101. Let's go to Mark Gautreaux. Anything to report to out of San Jose or your area?
No, still trying to work through the whole closing down of a trauma center thing. And nothing further to report on that. I actually had 2 questions for Glenn. One on the subway thing. Has there been any talk in the city of installing platform screen doors to prevent some of these incidents. I mean, most cities in Asia have the tracks screened off. You can't actually get onto the tracks. And then the other question was, has there been talk with respect to the e-bike batteries that in San Francisco, they just passed an ordinance saying that the batteries had to be underwriter laboratory approved, because the fires that we've been having have been a result of, you know, a lot of jury rig batteries or bike shops daisy chaining chargers in an unsafe way, and that a commercially purchased e-bike is no more dangerous than your laptop.
Yeah, those are great questions. You know, the underwriting laboratory, the UL sign, I guess basically from Chicago over 100 years ago, that's great. But as I tried to discuss last year at Eagles, you know, you go to a dollar store, these knockoff batteries have that UL label on. And the marshals would say to me, Doc, do you really think that you can get this battery for $2 where it costs $24 elsewhere or whatever the price is? And I thought, no, you're right. But it comes with this fake label, right? It's a little sticker that's on there. And so it's really unfair to the general civilian population where you go and go, wow, at Lowe's, this costs $24. Here I can get it for $2, even these extension cords, and yet they're not real. And so the city ordinance would have to go on to these dollar stores and tell them, you know, we're checking your merchandise, and if everything is, if it's counterfeit, you can't sell it and you'll be fine. I think that's the next step that they want to go to. As far as these barriers, yeah, the MTA, the Metropolitan Transit Authority, has sent their members to their leadership to countries like Japan and things, and they do have these things where even like Orlando, the train door at the airport doesn't open, you know, anywhere else except where the barrier is, and then when it opens, it opens altogether. So they came up just a month and a half ago with these screen barriers, right? So they put them up in a couple of stations, and they only did it like every 18 feet. And they're like, well, these are statistically where people might stand a little bit more because they anticipate the train door to open here. And the media went crazy on them, saying, you got to be kidding me. You think this is going to protect them? Look at the gaping spaces between these short 6-foot little fences. I mean, and so it's not working. They're like, well, this is some protection, but that's not gonna, you know, it's not anything like some of the Asian countries and even the Orlando airport that I've seen where you can't physically get onto the tracks. When the train is there, the door opens and then the glass compartment opens so that you can actually enter. It's not, they've considered it and their solution was just horrible.
Yeah, it's interesting because yeah, I mean, it's not just Orlando. That was one of the first ones I've ever seen. You're right, but I mean, it's in Las Vegas, it's in Dallas. You know, the same concept. That's what I was thinking too. So that's interesting. All right, well, what can you say? It's New York, right? So, but it's the cost is going to be significant. I'm sure that's what's probably holding things up out of that end, but we'll have to see. All right, let's quickly go to a couple. Let's run up to David Obert up in Vancouver, Victoria area.
Thanks, Paul. Not too much to report on my end. One of the things that's in my portfolio on my desk at the moment is we're looking at increasing we're adding protocol 38, which is the advanced send protocol, which we haven't had yet. So that's just hopefully streamline how we interact with our policing partners when they have somebody requiring medical attention, either in their care or in custody. So that's what I'm working on at the moment. But otherwise, things seem to be moving along here in Vancouver. Weather's turning nicer.
Yeah. Will you be able to join us in June, you think? And can you present some of that stuff?
I am looking into my schedule right now. I'm hopefully about to get my clinical schedule for June shortly. So I will hopefully get back to you soon.
Good. It'd be great to have your contributions. That's the thing. Okay, Shay, what about Denver? Anything tell us out of there? You can tell us what's going on out there besides snow. Are you even at home? Are you able to get out? Are you there, Shay? I don't know if you could hear us or not. Shay Gillen?
There I am. Yep. I was shoveling and listening and multitasking. So yeah, we got 22 inches where I'm at. So 20
inches? Wow.
22 inches. Yeah, we finally dug out today. That's the big news around here. The other thing we're continuing to work with is the migrant crisis is slowing down a little bit. But as we're starting to house more of our undomiciled population and some of the migrant population, seeing our calls for service kind of ticking up at some of these new housing areas. And trying
Yeah.
to mitigate those frequent calls. So yeah, the newer long-term shelters have become our like top 3 calls for service in the whole city. So yeah, we're kind of mitigating that at this point. So it's good otherwise. Yeah.
That's a lot of snow, I'll tell you. When did it start? When did it start snowing? What time of day was it?
It's kind of late Wednesday night, and then it snowed
Yeah.
all day yesterday, most of the night, at least down. We're in the south part of Denver here, so it's a lot deeper down here.
It's interesting because those of you who live in snow belts will know what I'm talking about. What I remember one time, for the first time, my wife, who had been from Texas, we were up in New England somewhere, and I suddenly woke up at like 4 o'clock in the morning, and she goes, "What's wrong? What's wrong?" And I said, "I bet you it's snowing." It's just, why? Is it? It's so quiet because it just, it does that thing. So things kind of do quiet down during that period of time. So that's why I was curious to know when it started, because it reminds me of memories of growing up in that area, and you knew when it was snowing outside often. So
Yeah,
whereas in
almost
York,
daylight brightness and quiet. So yep, very much
yeah,
so.
I don't know. I don't think that happens in New York too often because you still got so much noise there. But but it's it's an interesting, similar kind of thing. And then speaking of which, let's go over to Mick in Ireland. And any snow there today?
No snow today. There's a funny yellow ball in the sky. I'm not sure what it is, but I'm not sure it'll be here for long.
Oh my God, it's great. It's a bright, shiny, yellowish thing. Okay, good to know. So it's good. Hey, anything to report? Anything new out there, Mick, that we should know about as I wrap this up, because we're right at the witching hour here.
Not. Has time changed for you guys then? I must
We
come
were,
on very late
we
then.
changed. Yeah, I put that into our notes that we changed, and
Oh.
then you catch up next week. So there's like a 2-week period where you guys are behind us. So you'll change next weekend, correct?
I think so. Yeah.
Yeah. So I think there's a 2-week period. So we were, you're only 4 hours away from the East Coast at this point in time. So yeah,
So
it's a
the
little.
only update from us would be in our little part of the country. We have a FLA festival, it's Irish Country Music Festival, coming up in August, and the preparations are up for that. So the town is 30,000 people, and they're expecting 700,000 into the town for a 7-day period, which is going to be a challenge.
Now, are you talking about down where you work in Wexford or up north?
Yeah.
Okay.
Yeah, in Wexford. So every community football field, soccer field, rugby field, hurling field is being turned into a campsite for a 10-day period.
Okay.
As well
got
as
it.
every hotel, bed, breakfast, any place people can be put is they're being used.
And you're going to be outlawing beer, correct?
Oh yeah. Yeah.
Yeah, that's right. So good news that you won't have too many drunk people, right? So, all right. Well, what can I say?
The one thing that's been coming up now, so that they're looking at passing a law to allow alcohol sale on a 24-hour basis. So we have restricted, I know it doesn't seem it from outside, but we have restricted hours. So you can't sell alcohol after 12 midnight unless there's a particular licensing thing. And a lot of the media are coming looking for commentary on, do we think this will lead to higher EMS or hospital usage in the additional hours they're open? And I wasn't sure, but I don't know if there's any place in your system where that's been a new thing. Has there been a demonstrable trend in increasing utilization when you've increased the hours of alcohol sale?
Yeah. So I don't know anything about increasing the hours of alcohol sale, but I'm just clear it's going to have an impact. Yeah, even if it was minor, there will be an impact. It has to be. So, and from my point of view, but I wish there was some way we can define it better. All right. Anything else then, Mick? I'm going to move. Maria's doing well and the kids doing good, I hope. Right.
All good. All good.
David,
Big
anything
rugby
else?
match tomorrow.
David Miramati's, anything else to report out of San Antonio or we should know about?
No real big updates. I just love the discussion about trauma and geriatrics and the perinatal stuff. I'll be glad to be on panels with you all.
Yep, good. That'll be great. Okay, AJ, anything we need to know about? Bill, I'll come to you next, but we got to get off here pretty soon. Okay. AJ, anything from you?
No, I posted a video that Scotty Bolider did a cadaver video that shows blood accumulation in the pelvis and the application of the SAM pelvic splint. Pretty dramatic. It's good stuff.
Okay, good. And maybe since we may have, who knows, we may have a discussion since there's not 100% agreement about the pelvic binders right now, or maybe people want to do it. That would be a good thing to show. I don't know if we could do that during Eagle Creek, or just to the main audience, showing the pelvic binder as a quick presentation there, and then show that. So keep that in mind, and maybe we can have someone show it then. It'd be great.
Yeah, free to do it.
All right, good. And then Bill, anything we need to know about out of California from your point of view? Probably make it real quick.
California is pretty quiet and calm. We pushed our snowstorms onto Denver so they could handle it now.
Yeah.
COVID is still here, but less for respiratory, down under 2%, but that's still 20 deaths a day in California from COVID.
So one of the interesting things I've begun to see, just clearly anecdotal, but usually I'm picking up on this stuff, is that there's kind of a quasi long COVID that comes, or people have a longer bout, and it involves afebrile, everything else is fine, but you just basically don't feel like eating, and then everything that you have just makes you feel like, you don't want to eat it. It's a classic thing you used to see with people with severe hepatitis, where they didn't have a taste for cigarettes or food and all that. Or if they do, they just can't, they don't, and so it's not involving a lot of vomiting. They just don't want to eat anything. And it's almost behaving like an ileus, actually, in some respects. But it's not, and people are still, moving. There's nothing else. That's all it is. It's just a severe nausea, that kind of thing. So have you seen that or know about it?
Well, we've seen everything with COVID, and especially long COVID, where people get all kinds of symptoms, neurologic, they get GI, they get emotional things and everything else. And we're still studying the effects of it. And what we have is a large clinic, which is literally long COVID clinic, which is a new clinic that is just taking care of the multiple complaints from these individuals, many of which we have documentation are real. So these are not just psychological or emotional issues, they're real physical entities.
Yeah, no, I get it. I just finished writing a paper about a potential cure for COVID, at least for the ones who had it from the original, what you want to call it, the native virus or whatever. So any event. So, all right, I'll try to send that along to you. It might be of interest. It may be, at least it gives you an idea about the mechanism. So that's what's kind of cool about it. All right, everybody, we better get going. So welcome back, my friends. Everybody have a great St. Patrick's Day. I hope you all survived the Ides of March and didn't have to beware of it. And so we'll move on to seeing you all next week again. Welcome back, my friends, to the show that never ends. See, March 22nd, I'll probably be in Dallas. Okay, well, thank you so much, everyone. Take care. Bye-bye. Good to see you. And you'll still, hey, Mick got off. I was going to tell Mick it's still going to be early again. All right, good night. Okay, see you later, David. Thank you for everything. Okay, take care.